The pelvic tilt is one of the foundational exercises in lumbar rehabilitation programs worldwide, and it is also one of the most commonly performed incorrectly. Done correctly, it trains the deep stabilizing system, transverse abdominis, multifidus, and pelvic floor functioning as an integrated unity, and re-establishes the lumbopelvic neuromuscular control disrupted by back pain. Done with any of the three most common errors, it trains compensatory movement patterns instead. In some cases, it actively reinforces the dysfunction that rehabilitation is trying to correct. Error 1 is using the gluteal muscles instead of the deep stabilizers. This is the most common error, and it occurs because most people's first instinct for rotating the pelvis posteriorly is to squeeze the buttock muscles. Understanding why this error matters helps with motivation to correct it. The gluteal compensation produces the visible pelvic movement but completely bypasses the deep local stabilizer activation that is the actual therapeutic purpose of the exercise. Gluteal contraction does produce posterior pelvic rotation, but it does so through a global strategy rather than the local deep stabilizer activation that is the actual therapeutic goal. This compensation is especially common in gym-trained individuals who are accustomed to producing movement through high voluntary contraction of large muscle groups and may never have trained the deep stabilizer system at all. When comparing activation profiles, a glute-driven pelvic tilt shows high gluteus maximus activity with minimal transverse abdominis involvement. A correctly performed tilt shows the reverse. Clinicians who use EMG biofeedback to teach the pelvic tilt regularly observe patients who believe they are performing the exercise correctly but show almost zero deep stabilizer activity on the monitor. The compensation feels identical to the correct movement from the inside. The cue: place 2 fingers gently on your lower abdomen, about 2 centimeters medial to each hip bone, and focus on drawing that point inward and gently upward. No visible abdominal bracing, no breath holding. Let the pelvis rotate as a consequence of that deep activation, not as a deliberate hip movement. Feeling the transverse abdominis engage under your fingertips before the pelvis moves confirms the deep strategy is activating first. Error 2 is breath holding or breath reversal. Many patients instinctively inhale and hold the breath while attempting to brace the core, bearing down against a closed airway. This breath holding habit develops as a protective reflex across many physical activities. It is an instinctive way to increase trunk stiffness under anticipated load, and it becomes automatic over time. In the pelvic tilt, it is counterproductive. The correct breathing pattern: slow exhale through a slightly open mouth as you perform the tilt, allowing intra-abdominal pressure to reduce naturally and the pelvic floor to gently lift as the pelvis rotates. The exhale and the movement should be coordinated, happening simultaneously, not one after the other. Patients who struggle with this coordination often find it helpful to imagine blowing out a candle slowly as they begin the tilt. The mental image of a long, steady exhale produces better breathing coordination than direct breath control instruction. A simple self-check: place one hand lightly on your lower abdomen and exhale slowly while beginning the tilt. If your hand moves gently inward, the breathing is coordinating correctly. If your hand moves outward, or if you are holding your breath, the pattern needs correction before the exercise achieves its intended purpose. Error 3 is over-flattening, pressing the entire lower back so forcefully into the floor that the lumbar curve is completely eliminated. The goal of the pelvic tilt is to find and rehearse neutral. The lumbar lordosis reduced to a point where the lower back is in gentle contact with the floor, not pressed hard into it. Many patients, once told to flatten the back, go as far as possible until every trace of the lumbar curve is gone. This creates extreme posterior tilt, which actually increases posterior disc loading, the opposite of what most lumbar rehabilitation is working toward. One way to find the target range: place a folded piece of paper under your lower back before starting. The goal is to feel gentle paper contact, not to press through it. When all three arrows are corrected simultaneously, the exercise feels considerably more subtle than the compensation versions. Much less effort, much more control. That is correct. The deep stabilizers generate force through sustained low-level tonic activation, not through the effort pattern of global muscle recruitment. The full guided exercise demonstration with all three correction cues is in the link in the description.